everyone. Welcome to the Christian Health Service Corps Iron to Silver podcast. We hope this will be a resource for you. We hope it will be your source for insightful conversations with expert guests in the area of global health, patient safety, and improving quality of care in low and middle income countries. Join me, Greg Seager, Christian Health Service Corps founder, and Dr. Sarah Pruitt and Dr. Kelly Frazier as we share stories and explore strategies to improve healthcare in low and middle income countries. Well, hello, everyone. Welcome to our podcast on maternal health this time around. I'm here with Daniel and Priscila Cummings. I'm Greg Seager. For those of you who don't know me, I am the CEO and founder of Christian Health Service Corps. So this is a podcast Christian Health Service Corps does on best practices in global health. And I wanted to introduce Daniel and Priscila. They've been with us on the field in Angola since 2014, right, guys? And then before that, you were with Samaritan's Purse post-residency there. Daniel's an ER physician, and Priscila is an OBGYN, but I'll let you guys share maybe a little bit about your background, where you went to medical school, where you went to residency, because I know that'll be of interest to some folks here.
All right. Yeah. I'm Daniel Cummings, and this is my wife, Priscila. And my medical background is I went to medical school at University of Rochester, and then for residency in emergency medicine at the Hospital of University of Pennsylvania in Philadelphia. And Priscila was at the University of Michigan for medical school, and OBGYN residency was at the University of Pennsylvania Hospital. So we both met in Philadelphia during our residency. It was fun and exciting to meet somebody else who was also interested in serving and working internationally. And we met somebody else while we were on a rotation during residency in another country in Niger, who recommended that we look into or consider Angola because of the Portuguese language that Priscila already spoke. It made it quite a natural thing to consider. And we found we encountered Kalukembe Hospital, where we currently serve, or will be going back to serve. We're currently in the States, but we were there visiting while we were serving at another surgical hospital in the provincial capital of Lubango back in 2012 and 13. So that's what led us to Kalukembe Hospital, and we have an interest in caring and working in hospitals with our more district-style basic services offered, such as surgery, obstetrics, general medicine, pediatrics, HIV, TB care. So quite a variety that are at a basic level for a typical district hospital style in sub-Saharan Africa.
And Daniel's ER trained, but at Kalukembe, he does a little bit of everything. And he actually even helps in the obstetric department too, because our volume as a district hospital is so heavy, and we get such critical patients that we need everybody involved in the care of these women. And the other thing that I have the privilege of doing while at Kalukembe is fistula work. And so we have a fistula program. I was trained in Lubango with the team there at the Surgical Specialty Hospital. And we've been able to expand the fistula services in the country. When we started, there were really only 2 places in the country that had provided care for these women. And Kalukembe was the 3rd place. So it's a really special work. But our hope is not just to care for these women and treat fistulas and save women's lives when they come in, in a critical condition, but to prevent this from happening. So I'm really glad to be here talking about this because it's something that's close to our hearts and something we see every day at Kalukembe.
Yeah, I love
mortality. I don't know if we've introduced it yet.
Yeah. I love Kalukembe. It's such a unique place, and I got to visit you guys only once there, but I really it's got a unique history. And can you share a little bit about the history of the hospital before we dive into our primary topic here, which is maternal mortality there in sub-Saharan Africa? But I know that some people will be interested in a little bit about where you're serving and what maybe the history of that place is, because I think it's just such an amazing old mission station that you guys have done such an amazing job of really, rebuilding some of the infrastructure and some of those things while you're there. But give us a little background on Kalukembe.
Sure. Kalukembe was a mission station that was started in the late 1800s by a Swiss missionary who initially his interest was in rehabilitating ex-slaves. And it was started right on a highway and a main slave trade route where we still have mango trees that line the roads that would take slaves from the interior and the area of Kalukembe to the port city of Benguela. And there are still documents that you can find that will say cargo of origin Kalukembe, referring to the slaves that came from that area. Then in the 1940s, 42 actually, there was another Swiss missionary who came and he settled there with his family, young family at the time, and started medical work. He was trained as a doctor, and he began a mission, a station that was initially a health center, then eventually developed into a hospital for that region. And that's how it was started. He also started a Bible school, a lab tech school, and a nursing school. Pretty busy guy, this doctor.
Oh, that's right. Yeah. What was his name again?
His name was Adolphe Brechet. Okay. And his son also served after him, Jean-Pierre, who just recently retired from Angola. But anyways, they started the medical side of the work, and have continued it. There was initially a lot of work with leprosy patients, and then into tuberculosis as well. But it's always had surgical services as part of its care and inpatient care. They even had a section on the mission station to help mothers of malnourished kids to learn better practices for farming and nutritional foods such as soy. So there's been an interest in holistic care at the mission station, even from the beginning when it was rehabilitating ex-slaves and giving them hands-on practical tools and practical job and life experience. So right now there are still schools, Bible school, lab tech school, and nursing school. It is still about a 200-bed hospital with primary focus on inpatient services, but it does have outpatient services and vaccine care and tuberculosis as well. So that's kind of a quick background for it. Our catchment area means that we are the only site for emergency surgical services in a catchment area of about 500,000 people.
And one really neat thing about our hospital is that during this, we had a very long civil war that only ended in 2001. And there was a good 20 years where our hospital didn't have any physicians because that time the physicians were all foreign expatriate missionary physicians. And so during the Civil War, eventually everybody left. But there were 20 years where this hospital was still open and run by our Angolan colleagues and brothers and sisters, even during the middle of the war where the hospital was bombed, it was ransacked, but the community of providers there tried to keep it open, and they did. And it's one of the few mission hospitals that's left in the country. So it has a pretty amazing heritage and full of very resilient people. So we get to learn a lot from them.
Yeah, of the about 18 or 20 mission hospitals we're told that were open and in service in the 70s around the beginning of the Civil War, only 2 were remained open by the end, and Kalukembe is one of them.
Wow. That's it is an impressive history, you guys. And you guys are the only 2 expats there at the present time, correct?
Yeah. In Kalukembe, we're the only Westerners.
Okay. So we're looking for people to come alongside and join the work there, right? That's the
Most welcome.
yeah. So let's take a look at, maybe dive into the topic a little bit that we really came to talk about, which is this idea of maternal mortality and morbidity. Now, we know that sub-Saharan Africa has probably, and geographically around the world, one of the probably the worst level of maternal mortality, or MMR, maternal mortality ratios, and Angola being amongst the highest of that. Now, USAID, Division of Global Health, puts that probably a little bit higher than the statistics that have been reported to World Health Organization. But whatever the numbers, they're extraordinarily high. And maybe you can share a little bit about your take on that, and specifically your experience with that at the hospital.
I think the numbers are there's a lot of uncertainty because we don't even know what our denominator is. We don't know how many births are happening. And as a district referral hospital, we get all of the most critically ill who have come with great delay. So for Angola, the numbers vary somewhere between 200 per 100,000 to 600 per 100,000. At our hospital specifically, and this doesn't necessarily reflect our municipality, but at our hospital, we actually did a study and published in 2019 of the deaths that happened the previous year. We had 18 maternal deaths, which has been pretty consistent throughout our time there, and that is equivalent to over 2,000 per 100,000. So whatever the numbers, we are, with our own experience, even though, it may be a little bit different because we're rural, we're inclined to go with the higher end number. So there's
the estimates from the USAID put it a bit higher. That's probably because we only have the estimates, even for the number of deliveries that are done at health centers, is placed around 10% of all births. So majority, is that correct? Oh,
maybe in the past, so it's still not any good.
So using those estimates, it does seem to be that the higher estimates would make most sense about the mortality. Unfortunately, the country itself doesn't even report what their maternal mortality is. So we're basing these on models and estimates and trying to work from that. But that does seem to play into our experience. Our experience is that they often come in severe extremis, whatever it is the condition, whether it's obstructed labor as the primary cause of things, or if it's severe malaria or other infections. And our experience with those deaths, and I mean, quite a few that of lives saved too, but with the deaths is to see that, well, how is it that perhaps something can be done in the community before it gets to the hospital? The struggle has been to be working with government partners and others to see that it is not, certainly there are things that perhaps we could help with in optimizing quality care for our patients, but the bigger challenge is to see what can we do to reduce the barriers to patients who are having obstructed labor or complications in their pregnancies to be seeking care and receiving care sooner.
Right. The UN Sustainable Development Goal 3 is really the health area, and 3.1 is to reduce the global maternal mortality ratio, MMR, to less than 70 maternal deaths per 100,000. Now, the USAID estimates put that at about 610 per 100,000 in Angola. Obviously, you get the worst of the worst, those that were home deliveries that just, that waited way too long. So your numbers are probably statistically much higher than even that. And of course, the World Health Organization, I think it puts it at 222 per 100,000 live births. But I think you're right. It's such, when you can't really track the number of births, if you don't know your denominator, it's really hard to challenging. But whatever the case is, it's it's such a divergence from that goal, that sustainable development goal of bringing that down within 70 per 100,000 live births. You guys kind of have your work cut out for you there. But I like the idea of, what you're talking about of how do you get into the community, right? I think the big challenge that's we've struggled with in dealing with maternal mortality is that the health system have to be functional, and the providers have to be well trained in order to deal with obstetric emergencies. And then at the same time, the community level providers have to be trained to be able to identify those potentially, those women that are likely to have or potentially will have complications of pregnancy and childbirth, and those that are high risk. You guys are looking right now at doing a program that will kind of pull all those things together a little bit. And I'm excited about that and CHSC's role in help coming alongside you and helping you with that and the community with that. Tell us a little bit about that program and what you guys are going to be doing.
Well, we're really excited about this too. And like you said, the reality is complicated. The solutions need to be, multifactorial, and we so it's not just a simple solution. And so when we for our program for reducing maternal mortality has sort of three primary focuses, foci. But I think the foundational one is community education and outreach. And so we are planning, we already have a public health department at the hospital, and we're planning to grow that and to focusing on the communities that have already been affected by maternal mortality, to go there first to listen and to hear what were the barriers for these women, for these families to come to our hospital. And then also bring in teams to teach the community leaders and the families, to educate them. At the community level, we need to first develop those relationships, to have a posture of listening and of partnership, and then come in with to educate them. So I'm really excited about that community work that we have planned. The other thing that we need to work on is the infrastructure of our hospital, to make it a hospital that's more welcoming and more effective in taking care of these women. I think we do a good job, but we can do better. One of the things that we need to do, I think, is to improve prenatal care at our hospital with ultrasound evaluations, as well as one thing that I think we're really interested in is building a maternal waiting home as part of our hospital infrastructure. That this would allow women who live in rural areas and would have quite a ways to come to our hospital, where they could wait their final trimester, or if they're at risk for other complications, where they could wait within walking distance of the hospital. And that we think would be really helpful in reducing the barriers to care to come to our hospital. And then the final, and I think sort of very essential part, is training and capacity building. Because you can talk with the community, you can build infrastructure, but if you have no one to actually care for the patients and care for them well, it's all going to be for naught. And so we have a program where we're going to be training both nurses and midwives in obstetric care, as well as Angolan physicians with a partner hospital from Lubango, doing a rural medicine training program at our hospital, where they will have more exposure to care for obstetric pathologies and interventions, as well as surgical interventions, but also family, whole family care as well, like pediatric work. So we're excited about that. We're working on the curriculum as well, and I think there's one thing that we're also really grateful for is the WHO's protocols that we're going to be using as foundational for both our physician trainees, as well as the outreach that we'll be having with our government clinics and hospitals and other private hospitals. So we hope that that this education won't just be at our hospital with our clinicians, but will have an impact for our entire community.
Sure. The that idea of kind of multifactorial solutions is something that WHO is really good at in their program designing of that integrated management of pregnancy and childbirth is one such program. And I know you guys are going to be pulling a lot of the protocols and a lot of the education materials out of there. Can you speak into that a little bit in what you found in there? Have you, and maybe you can just share a little bit about that program so that people understand at least what it is.
Well, I mean, one of the things that we've noticed is a big challenge for our clinicians, as well as for the providers around our entire province, is that there really is very there's not much information for what is standard of care and what is evidence-based practice. And that's something that part of the problem is that there's not enough literature, there's not enough education. And so what we have done in prior little conferences that we've done and continuing medical education classes that we've done for both our clinicians and the communities is that we've published in part some guidelines that on managing obstetric complications or healthy pregnancy in that the WHO has in Portuguese. Unfortunately, they don't have everything in Portuguese yet, so we need to work on that. But given some of that of what is standard of care, what is evidence-based practice, and provided that as information for us, for our team, as well as for our colleagues. And it did bring, I think, it was a good point of discussion, but it was also just people were really excited to have that information and to know, how to manage, how to use oxytocin, how not to use oxytocin and misoprostol and that sort of thing. And, what are the signs of preeclampsia and eclampsia, and what do you do with that, So we've seen these resources as helpful, and we look forward to growing that as we build this program.
Are they available in Portuguese, or are you going to have to do some of the translation on those? I think some of them are, correct? Or
some of them are. The entire books are not, but there are a few protocols and sort of the sort of compressed versions that the USAID has translated, the summaries that the USAID has translated from the WHO. So the WHO doesn't actually have anything in Portuguese that I found. I can be corrected, and please, if anybody out there knows where I could get them, let me know. But there are a few summaries that we have in Portuguese, which we've provided. There are in Spanish, but it's just enough where our multilingual neighbors who are incredible, I just don't like. It's just a little bit more difficult to read it in Spanish, even though it's essentially the same thing. So Portuguese would just make it a little bit easier.
Sure.
But I think even more, the text is one thing, but another thing is really in-person dialogue, and I think that those courses and will make that stick more, and so I think that will be important.
Working through case by case with our nurses as well as trainees, it makes it always more helpful and helps it sink in.
Yeah.
Well, thank you guys for sharing a little bit about your work and what you're planning to do as soon as you get back. You've been home now for a bit of a time. It's been about 18 months or so, or 2? Yeah. So I know you're excited to get back, and we're excited to have you back there. So thanks again for sharing, and I look forward to seeing you guys soon. Hey everyone, we hope you enjoyed this week's episode of the Christian Health Service Corps Iron to Silver podcast. Christian Health Service Corps, we are passionate about bringing quality healthcare to the world's poorest places. If you share our passion, we'd love to hear from you. Our website is www.healthservicecorps.org. Thank you again for joining us this week.
you.